So that was my thought. We'll start with Amber.
Oh, yeah.
Let's meet everybody. Introduce yourself.
Okay.
Tell us your... No, I'm just kidding. Tell us where you're from.
Okay, you're gonna have blue background today.
Okay. Maybe just to get things started, I thought I might run through what a patient might experience from beginning to end. So I first see the patient in clinic, and we go over their images. Most of them are coming from Mary Lanning, but sometimes they're bringing images from outside facilities. We have those images loaded onto the packs, and I go over the images with the patient in the visit. So I bring it up and I explain to them in layperson detail about what's going on with their condition. If they need a surgery or if they need more tests, we start with that, and we'll order tests and send them for more x-rays or MRIs or EMGs or CT scans or whatever it might be that they need. If they need a surgery, then we go into detail about the options. A lot of doctors will kind of come into a room, and what I've seen of some doctors, they'll come into a room and say, well, here's your problem and here's what we need to do to fix it, and it's just a couple-minute conversation. I like to talk to the patient in detail about what it is they have and do what we're all trained to do, and that is talk to them about their options. There's always options. One of my favorite things to say to the patient is there's always options in life. Some choices are better than others, but surgery isn't always the only thing that a person can do, especially in a circumstance where you come into a clinic and you've got a relatively non-emergent or non-urgent problem. So we talk about conservative treatments, whether they've done it or not before. We talk about it more and talk about the chances of improvement with that particular treatment, how they're feeling about what their past experiences may have been. And then we talk about the surgery that I feel like they might benefit from. Go into detail about that surgery, what the risks are, what the general technique is in layperson's term, so that they understand what's happening to them. Posterior cervical, we make an incision in the back, and I've got models in clinic that I demonstrate on with the patient, and that's helpful. Like the anterior lumbar surgeries, I go into detail about, in general terms, what we're doing, how we're getting there, what structures are in the path. Give them the opportunity to try and process that. And then, how I conclude a visit like that is always to say, you don't have to decide on things right now. This is a lot of information, and you may need to go home and think about it, get some support from your loved ones, bring your loved ones back. We'll go over images together to help make the decision that's right for you. If they want to schedule surgery, then we get Tony or Mel or Paige started in the process of getting their surgery pre-approved, and that's a whole other process that I'll have Mel give a description about real quick. If you could just talk about that. No, it's a pretty involved process that's different for each different insurance company, and pre-approval does not guarantee payment of services, blah, 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 all that kind of stuff. So, but that's part of the process as well. It's a big step in the behind the scenes of getting a surgery scheduled and approved and scheduled. At the time of the visit, I'm doing all of the notes and doing all of the orders and concluding the visit before I leave the room. I don't do it where I talk to the patient and then come back later and do the notes, because I think that just makes opportunity for potential error, especially if you're seeing 25 patients in a day and then trying to come back and finish all those notes later. I'd rather take a few minutes to complete those things, including making orders for operation, and that's where the boarding sheets come from, and how we're positioning the patient, some other orders, the laboratories that we do. Kind of revisiting the discussion that I have with patients. Some patients want the doctor to just tell me what to do. But I don't think that that's fair to the patient, whether they want it or not, because I feel like a patient really needs to participate in the process of deciding what's best for me. So I kind of force that. Most of the feedback I get from that is good. There's some feedback I've gotten even in Georgia that patients will say, well, he's an indecisive doctor, but it's not indecision. It's trying to get the patient to realize their participation in the process. So once we get all the orders done and everything in the encounter finished, then the patient goes and they're in communication with Tony or Paige about the progress of the pre-approval process and getting it scheduled through the OR and what times we have, what days we have. And then the patient comes for the day of their operation. So we, I talk to them about any new problems they've had, how their symptoms are, confirm that all the orders are in place and things like that. There have been issues with that in the past, but I think maybe we've got that ironed out with some new processes, some new workflows, where the orders were expiring. The patients would have their surgery at the 31st day, and the orders have expired on the 30th day, which is kind of frustrating for everybody. But so a lot of spine cases don't require, or I think that it's a lot of facilities don't require marking a spine case. The way that a lot of cases are indicated prior to the operation is that the marking takes place intraoperatively with fluoroscopy, so that you're operating at the right level in the right place. And so we use imaging a lot. You ladies know we're using imaging a lot in the operation. Not only their preoperative scans, but also fluoro with Chet and McKinsey and Whitney, and those guys are the main ones that help with fluoro. And we have that fancy intraoperative CT scanner that we use for image guidance. It's a newer technology that helps us be able to do minimally invasive surgeries, can plan. I don't think anybody's here from the cranie that we did the other night, but we use that device to plan the incision right over the tumor, plan the craniotomy right over the tumor, as opposed to making educated guesses as to where you make your incision. Used to be before we had navigation, which has been quite a while now. We've been using this technology for, it's probably going on 20 years that we've been using intraoperative live navigation. Before that, it was based on landmarks, and you measured the ear, and you stood back and got a big picture of the patient's head from a side view, and oriented yourself relative to the imaging. Now we can really be a lot more precise with how we make the incisions, how we get to the spot. But it's a process of setup, so it can be lengthy, sometimes before the operations, to get the patient registered and get the images made and linked up with the machine that helps with the navigation. So then we do the operations, and each operation is different. A 2-level ALIF is different than a 1-level ALIF, is different than a posterior cervical fusion, which is different than a lumbar laminectomy, which is different than a microdisc, certainly different than a craniotomy. So even though it's a spine operation, each operation is vastly different from one type to the other, but even more so, And I think this holds for a lot of specialties, but in some ways more so for spine and even brain surgeries, is that the anatomy plays a big role in making the exposure, the amount of arthritis that you have to work around with the bones and the joints, and for a spine operation or in a brain operation, where the blood vessels are, what other structures might be. The mastoids are shaped differently in everybody, just like the spine joints are shaped differently in everybody. The discs are shaped differently in everybody. So all of these factors affect an operation and making the exposure, how long it takes. And sometimes there's surprises around every corner that you can't predict necessarily, because imaging doesn't show you every little thing. But you get through the operation and then you wake the patient up. As far as the post-procedure, it's pretty straightforward. The anesthetist wean the anesthesia and wake the patient up. We usually are getting them back to the supine position if they've been prone, or the positioning in a craniotomy is usually a comfortable lounge chair position, so the head is up, or the head of the bed is up and the legs are down, and they're shaped kind of in that position. So we straighten them out, get them to their bed that here we call a cart, which I've never known of before, but that's an interesting new term for me. And sometimes that process can be lengthy. For instance, Lacey did a fantastic job the other day extubating the patient without having her cough or have big swings in blood pressure and stuff like that, and that was a very skilled technique to make it a smooth transition from being anesthetized to awake. But sometimes in the course of that process, that can lengthen the duration that the patient wakes up, so they are recovering for a longer period of time, which is part of neurosurgery in some cases. So they get to the recovery room. There's nothing really special in the recovery room that is necessarily different than any other process. You're implementing acute pain control or even hyperacute pain control, getting them awakened enough out of anesthesia to get them up to their room. Awakening from a craniotomy isn't technically any different than any other operation, especially the craniotomies that we've been doing here. Sometimes, if you're operating more near the brain stem, that can, When the Air Hits the Brain is a book that was written by a neurosurgeon. That's kind of a fun book to read if anybody's interested in that, but there's some truth to that. Things get a little bit different, and the deeper you are in the brain structures, the more anesthesia can affect things, the different ways the patients wake up and things. But generally, the wake up is pretty smooth and routine, and there's typically nothing special. So if things are seeming like they're taking too long, or the patient wakes up with a weakness, facial weakness on one side compared to the other, for instance, those usually aren't going to be expected changes, and so this would prompt us to evaluate that patient, maybe get a scan right from the PACU. Traumas and other more urgent cases can be a little less predictable in that regard, but most elective craniotomies are not going to have anything unusual happen. And so the patient recovers, they go up to their room. In some cases we use drains, some of the spine cases, and we've made changes over the months to try and optimize how the drains are treated when they're on the floor. So I don't know if this is a change that we'll implement to other services, but the hemovacs, for instance, were notorious for coming apart or the patient would catch it with their thumb when they're trying to change their positions in bed and things like that. And invariably they would come apart. I'd like to not fall back. There we go. So we cut it a lot shorter with a lot less slack, and Denise helped a lot in brainstorming how to fix that problem that was where the patients were pulling their grains apart. I'm positive none of the nurses were doing that on purpose. So,
where are the majority of the patients going?
well, for elective spine cases, the majority are just going to go to the floor.
And med surg.
Mm-hmm. Yeah, ward care. A craniotomy will always go to the ICU, just as a precaution. Even elective cranies, it's just a normal thing. But in the 12 years I've been doing this, a regular elective cranie just usually downgrades to the ward status the next day and discharges. For instance, that lady that we just did operation on last Friday who had a brain tumor, she's left the hospital on day 3. So the recoveries, even in that case, it was more of an urgent case because she came in through the ER, was having some symptoms. This mass was discovered. We operated on it in a fairly rapid manner. Not because it was harming her in a way that was threatening her life, but under those circumstances, sooner is better than later. And she made a great recovery and left the hospital soon. So, and it's the fine work that we all do together, collaborating and cooperating to make that happen. So this patient recovers and they leave and they come back and see me. My post-op course is post-operative visits at 2 weeks, 6 weeks, and 3 months after the operation, routinely. And then if there's other visits, though, that the patient needs, then we modify that from there. We check the wounds, we take steri strips off at the 2-week visit, or we take staples out at the 2-week visit. That's about it. So that's the course of a patient through neurosurgery. This was supposed to be a question and answer session, so. Yes.
Are you doing like, you know how Dr. Brosnahan was doing a lot of the like pain injections and stuff? Are you doing that too?
I'm doing some. I do some. Dr. Rajput does the more intricate interventional pain management injections. I've been doing some of the, I use that modality as kind of when we're evaluating a patient, whether we're going to focus on conservative management or surgical management. So when the patient hasn't had a full, maximized their conservative treatment regimen, either they have had some physical therapy but no injections, or not had anything, especially if they've got, pathology that could be surgical. I get them started on, if they're in favor of engaging in intervention, injection treatment, interventional pain management, that we typically consider part of the conservative management regimen. I'll do an epidural steroid injection. Basically, I'm limiting it mostly to epidural steroid injections in the lumbar spine and SI injections.
Are you doing those in your office?
In IR.
Oh, wow.
Mm-hmm. The specials area. And so the other thing that I like to tell patients is any treatment is their prerogative. So, some patients have had experience with physical therapy and they felt like it made their symptoms worse. That's a factor that I record in the record, and when we're trying to get approval for surgery and things like that, these are factors that hopefully they take into account and not try and pigeonhole the patient into, fitting their protocol and their guidelines, because not all patients do. I don't really engage protocol-driven patient care. I mean, everybody's different in the problems that they have and the way they're going to respond to treatments and things like that. So that's another way that I engage the patient in their health care. Lori looks like she has a question. Jenny definitely has a question. What's up, Leif?
My preschool question of the day. Is the gel inside of the lumbar discs the same consistency as jelly donuts?
No, it isn't. It's a tissue that is very sticky. Some people know this, right? That have helped me in the OR. Amanda was there yesterday. Can't get that stuff off your fingers. The nucleus pulposus. So let's explore that a little bit. The anatomy of the disc is that there's a tough fibrous outer ring called the annulus, and a herniated disc or a ruptured disc is where the annulus tears, and the nucleus pulposus extrudes from that opening. That's a herniated disc. A bulging disc, on the other hand, is a disc where its overall structure has become weakened due to arthritis, and so it kind of, bulges out around the edges, kind of like a used sponge. If you were to squeeze a brand new sponge, it's a lot firmer. It doesn't have a lot of pliability to it, but a used sponge is soft, and you can squish it, and it kind of squirts out around the edges. So that's the analogy I make with patients too. But so it's not like a jelly donut. It's actually a tissue that can tear. And there's not another. I've tried to figure out a better analogy other than jelly-like stuff, which is what everybody seems to say, but there isn't one. It's its own unique tissue.
So if you had a patient on ICU that had their intracranial pressure going up,
Mm-hmm.
when I worked at St. Francis there, a neurologist would just have the bedside like drill a hole in their head and put the drain in. Do you do that?
Mm-hmm. You can do that. I actually do prefer to do that in the OR because the conditions are a little bit more controlled. In Georgia, I found that, and it hasn't really come up here. In Georgia, we could get them to the ICU or to the OR just about as fast as we could get everything together and do it on the floor. So, and plus the conditions are more controlled. You have, even if it's under monitored anesthesia care, which is what everybody knows as MAC, monitored anesthesia care. It's more controlled. I mean, that's pretty much the same thing you'd be doing on a unit to do that kind of procedure. So you have extra personnel, you have extra tools to handle something if it were to come up, rather than have something happen in the ICU and then only have to rush them to the OR later. And you're in a more controlled environment and you can deal with things as they come.
Are we taking moderate to severe TBI patients at all? Are we still deferring them for their?
We're working that out. I think we can. There have been a couple that have been shipped out. I'll leave it at that for now.
Question about hardware. So if you're doing craniotomy type things, and we can even throw the trauma category in there, what are some of the things that help you make a decision between trying to preserve the bone, the natural tissue, versus moving to something like a plate?
Okay. Even the most complex skull fracture can be reconstructed with with the cranial plates and screws and various tools that have been devised to make that. There's a whole myriad of different little mini plates that we use to cover burr holes or to span across the craniot from bone flap to intact calvarium. A whole bunch of different ones of those, and then they even include sheets of titanium mesh that can be cut and contoured and shaped the way you need it to. So I've had the occasion to reconstruct in a fairly complex way skull fractures in the past. So a skull fracture, even a horribly complex skull fracture isn't necessarily cause to get rid of that bone flap. Contamination and infection is pretty much the circumstance where you would have to get rid of a patient's native bone and fit them with a prosthesis. And depending on the circumstances, sometimes that prosthesis might be the mesh that comes in just the general flat mesh that we can contour and shape. And sometimes it might be more complex. There are pre-shaped prostheses, and then there's custom prostheses that can be made. So the short answer to your question is infection is the primary circumstance in which you would not replace a bone flap. And even if it's let's say it's a complex open skull fracture with degloving and everything, I think it's still fair to wash that, scrub it with betadine, and reconstruct it and try and replace it. It might become infected later, and there's fairly high incidence of that in complex, largely open skull fractures. But for instance, a skull fracture that just has a laceration over it isn't necessarily, there's no more infection there than any other way. The only last thing I was going to say about that is once the bone flap does need to be, there's two things. Once the bone flap is decided to be contaminated beyond salvage, and then there are programs that Stryker and Synthes, and it started with Stryker was the first company that did this, is they could take a CT scan of the patient's skull, a CT scan of the head, and construct a prosthesis that was contoured exactly in the way that, they had complex programming algorithms to reproduce the contour that the patient had there when they had their actual bone, and then they would make a prosthesis from peak using programs, and now they're 3D printed and all that kind of stuff that they can do now that they didn't used to do when that first started. So I'm sure the price has come down significantly over time. It used to be about $20,000 to have one of those prostheses made. So the only other thing I wanted to mention about craniotomies that a lot of people might not understand is that once you remove a bone flap, you have totally devitalized that part of the bone. So that then becomes a foreign body. When you're replacing it, it doesn't heal back with new bone or anything like that. Now what does heal is a very tough fibrous scar heals between the intact calvarium and the flap that you've replaced. It's so strong that it's as good as bone, but it's not actually bone. So the cranial plates that you have there are very sturdy, and they hold everything in place, and then on top of that, the body scars that back in. But it doesn't heal it doesn't regrow blood supply or anything like that, so infection is greater in those circumstances. It's essentially a foreign body at that point.
Are we doing that at all yet here? Because I haven't been involved in the cranies where we're sending them to lab to get them freeze-dried later, like?
We haven't done that yet.
Okay.
No, we haven't needed to.
Or did you do the ones where you put them in that
I've never put it in the abdomen, but that is a technique that's used by some. There's some debate in the literature whether or not there's an increase in resorption once that's done. So a technique is to make a pocket in the patient's subcutaneous tissue over the abdomen and store it there. Because I guess back in the 80s or whenever that technique was first developed, heck, I don't even know when, frankly, but could be much older than that, but it was kind of send the bone flap where the patient goes, and what better way than to keep it on their person. But what they found is that number one, it could be resorbed here, and you put it in this big and you take it out this big, and so then it doesn't fit. But the other thing that has been observed, and I've seen patients that had this, even though they take it out of here and replace it back into its position on the skull, but then it gradually continues to resorb over time. And I've seen patients who had their bone flap that then shrunk in a way that caused it to then sink back in as though it weren't there. So I've chosen not to do that. I think the incidence of that is less when you store it in a -70 freezer. The downside is that you got to make sure that the bone flap goes wherever the patient goes, and that can lead to problems too. So if the patient's in skiing in Vail and they have a craniectomy and then they've got to come back home later and need their bone flap replaced, that can be tricky, and bone flaps get lost, and then you need a prosthesis. So there's upsides and downsides to all of it. So I would store it in the freezer, and I think that we established a protocol for that when I first got here. Something I'm pretty sure we did, but I'll admit I don't remember.
Going back to trauma, one of the questions that kind of comes back to me a lot is C-spines
Mm-hmm.
and clearing the C-spines,
Mm-hmm.
especially on those that get admitted. A lot of calls get made back to me with the two nurses that the C-spine is negative for CT.
Mm-hmm.
Why does the patient still have a collar on? And you probably have that same question. I understand that, but a lot of people may not understand that, and maybe because they may be intoxicated, they may have a
Right.
DCS of 10 for those destructive injuries.
Yeah, exactly. It comes down to distracting injuries. It comes down to some degree to distracting injuries. On the other hand, and so if a patient, though, is asymptomatic and they're not having any problems at all, then the literature does reflect that those patients can be safely taken out of the collar with an exceedingly low incidence of having any problems after a patient's been cleared. So having distracting injuries unto itself is not a reason necessarily to keep a patient that doesn't otherwise have concern for a cervical injury to stay in a collar. But the more common is in the absence of radiographic evidence of an injury, the patient still hurts. And so we examine the patient first by palpating. We keep them kind of in a still position. You reach back there with your hand and you feel around things, and if they say it hurts, then when you do that, then they keep the collar, even if there's no injury that's obvious. On the CT scan, one thing that you come back later and do an MRI, but that's an expensive test too, and there's been research on the utility of an MRI in the circumstance of a radiographically negative cervical injury in a patient who has persistent neck pain. And some of those studies suggest that a flexion extension X-ray is just as valuable or just as indicative of a problem as an MRI. So there's still a lot of debate in this area. A lot of times what you can do is a patient, trauma patient gets banged up and they're sore all over the place. And so you leave the collar on for a day, and in most cases you're able to wean that collar off or take the collar off the next day because they're no longer painful. In a patient that is persistently painful, you would decide whether it's appropriate to do either an MRI or a flexion extension X-ray based on physical exam findings and other radiographic signs. And you'd make that decision in the hospital in an attempt to try and get the brace off of them if you can't determine that it's mostly muscle pain or muscle tenderness that they have. For instance, if you're feeling around on a patient's neck and they say, yeah, it's real sore when you touch here, well, that's more of a muscle strain than it is. But if they're tender right in midline spine, then there might be a concern, and the concern would be a ligamentous injury that you can't see on a CT scan, of course. Even an MRI isn't great at reflecting the ligamentous status, and it can still be a question of whether there's an injury or not. So that's a matter of ongoing debate in spine trauma, certainly.
So the big things for staff to keep track of is continued neck pain when other pains may have resolved, and then pay particular attention if that is a midline related
Yeah.
pain.
Mm-hmm. Yeah. That wouldn't be anything I'd ever expect a staff member to evaluate. That's something that either myself or the trauma doctors come in and feel around on the neck. So not only are you feeling, but the other element of clinical exam there is to have a patient go through range of motion. So say they're no longer tender on palpation, but so then we have them flex their neck, extend their neck, tilt their neck, and rotate. And pain in any of those vectors of motion would prompt you to continue a C-collar. And then sometimes patient will leave the hospital with a collar if it's an equivocal injury, you can't tell what's going on. They'll leave a collar and come back and visit in clinic in 2 or 3 weeks and reevaluate. If their pain is resolved, then you'd take them out of the collar, and if it hasn't, then you'd do more studies, depending on how you evaluated them initially. If you got an MRI in the hospital, it might be appropriate to do a flexion extension view, or vice versa, to check for any more signs of injury. At that point, it's been a few weeks after the incident, and if there's a dangerous problem, like a shift in the alignment of the bones of the spine, then an evaluation on imaging would reveal that at a later time, most likely.
Any other let's say C-spine's been cleared and the collar has been removed, but we haven't admitted a patient to the unit, and we find that when they're experiencing symptoms that maybe they weren't earlier, would you prefer that nursing initiate C-collar placement or contact you first?
Contact us first, yeah. Because a lot of that is circumstance driven too. I mean,
Question about material preference. So I realize a lot of surgeries use the titanium alloys and everything, but I know that there are some of the higher end hardened plastics that are also available too. Is that just surgeon's choice on what materials they like to use, or is it more of what you're trying to fix?
There's different equipment for different purposes. It's a little of both. I like the newer technology of what we call porous. It's the surface structure of the new implants is microscopically designed to match that of cancellous bone. So it's got some pits and dips and spicules and various other shapes that bone cells like, that we've found promotes better migration of the osteoblasts and integration of the implant, especially the inner body implants is mainly what we're talking about here. The implants that go between the vertebral bodies in place of the disc. And so there's a lot of research in this area over the years and even decades as to what works best. And for instance, there are some factors such as how those devices flex and bone flexes is part of what gives it its strength, and titanium doesn't flex. It has almost no moment of elasticity. But PEEK, this polyethyl ethyl ketone, which is the high-grade medical plastic that we use for these intervertebral devices, PEEK has a very close elasticity and strength and flexion moment to bone, so it actually integrates quite well. And then to add a porous surface structure on top of that is a pretty good device. You have no particular point of weakness, whereas in a titanium device, it's my view at least, that the point of weakness is the interface between the bone and the implant, because the bone has its strength and different modulus of elasticity, the way it might twist on itself or flex on the internal structure in a highly microscopic way, whereas titanium is much more rigid. So you've got if you think about it, to say bone is flexible is a little bit of an oversimplification, but you've got this flexible structure next to an absolutely rigid structure. So there's going to be a weakness at that interface, whereas in the implants that are PEEK based, you've got a moment of elasticity here that matches very close to that of bone. So there's really no weak points except the direct interface between the implants. And now that we have this porous technology where the bone can grow into the edges of that, it's almost as good as having it be bone on bone. So
Does insurance play part on that, or you can just put in whatever implants you have to get that? Certain insurances plays a role. Certain insurances say that they're not going to pay for certain things. Yeah, actually. So for instance, United Healthcare prefers to pay more for BMP, bone morphogenic protein, which is a bone promoting factor that's been studied and well documented to create successful fusion. But it's more expensive than a material that I use that has bone progenitor stem cells that are harvested from donors. And the research, side-by-side research, shows that that material has just as good fusion properties as the BMP-based material that comes from Medtronic. And yet United Healthcare prefers to pay for the BMP rather than the Vivigen allograft. And so you get little nuances like that from here to there, from here and there, but it's not that common for the most part. You can use what you feel works best. Chet has an X-ray question.
I do? Okay. I really don't. What are some areas that you're looking for improvements on to make your patient care go more smoothly?
They were all looking at you, and then they all looked at me. That was kind of funny. I think everybody's doing quite a good job. I think it's a new service line here. I just encourage everybody to feel more confident in your ability to pick up something new that you haven't seen before. The skill is here. I think it's the familiarity with what we're doing and realizing that everybody here has the skill to do things that even that they might not be totally familiar with. Because it's a foundation. I have a lecture that I would give the young residents during training that intellectual independence, being a professional, in my mind, means that you have your foundation of the profession that you've learned. In the nurse's case, allied health. In doctors' cases, allopathic, medicine. But you learn this base of information as your foundation, and then you use your common sense to apply that knowledge to situations. A lot of people, and everybody's guilty of this, but a lot of people try to say, well, I didn't learn that, so I don't know how to do it. But it's not the learning of it that teaches you how to do things. It's the knowledge base that you create through that learning that allows you to apply your intellect to a situation. So, intellectual independence. Being able to apply your brain power to a problem rather than trying to put it in terms of whether you have or haven't learned something. We all have that capability, but I think the educational system in America kind of makes us feel like maybe we don't. Haven't given that lecture for a while. Yeah. So just having confidence in yourself to solve problems that you're not totally familiar with. And from what I've seen, everybody can do it here. That was a good question, Chet. Well, I think it was a good talk after all, even though I didn't have slides.
I guess we can ask the question back to you. Is there any questions you have for us? Our different service lines, we got quite a few here, so.
Not specifically. I think we just will keep collaborating and building one another's confidence, and y'all have patience with me and I'll have patience with you, and we'll all treat the patients.
That's our official slogan from now on.
Mm-hmm.
Well, I suppose we'll call it for this week then.
All right.
Thank you everyone for coming.